Hello and welcome to Health Professional Radio. I'm your host, Neil Howard. Glad that you could join us here today. Our guest is Mr. Joe Hamilton, Chief Clinical Outreach Officer at Mountainside Addiction Treatment Center, and he's joining us on the program to talk about benzodiazepines and how they've not only played a dangerous role in the opioid epidemic, but have actually started an epidemic of their own. Welcome to Health Professional Radio, John. How are you?
Great. It's great to be here. And thank you for giving me the time, because I've got grave concerns about the overshadowing, because of the tragedies of the opiate epidemic, of the next epidemic that people probably are not even aware of, which is the benzodiazepine epidemic.
Benzodiazepines, for our listeners who may not be familiar with that term, what are those drugs?
It's a new generation of barbiturates. It's used for anxiety, insomnia, and seizure. Back in 1977, the most overprescribed medication that was probably most familiar with people would have been Valium, diazepam. But since then, actually, Ativan and Klonopin are much more popular, and Xanax as well. So it's a class of medications that's been used for anxiety. The trouble is, even the anxiety specialists will say that its use is short-term, and the FDA recommends short-term use. But unfortunately, some people stay on for years and can really get in trouble with it, even though for the most part it's a pretty harmless medication when taken as prescribed by a doctor. When mixed with opiates or alcohol, can be fatal.
It's used for several different things. Do you think that is part of the reason that it is overprescribed or misused?
Yes, it's actually very effective, and people like the medication, particularly if some people feel overwhelmed by panic attacks and anxiety. It really, short-term, alleviates that pain. Some people use it as like a PRN as needed when they fly, if they have a fear of flying, and it short-term can be very, very effective. The trouble is, because it's something that people become so comfortable with, they end up taking it long-term. And then the irony is one of the actual withdrawal effects of withdrawing symptoms is anxiety and panic attacks. So what ends up becoming something that a person was fearful of and went to the doctor to begin with ends up becoming a challenge to come off. So, I mean, ultimately, people, we always kind of look at a need to develop skills over pills and being able to learn how to self-regulate, mood regulate your emotions and just kind of stay present and mindful. And that can actually be achieved through cognitive behavioral therapy, which anxiety disorder experts now see as the golden standard for treatment, not medication. Medication is short-term, but not a long-term solution. And as I said, if you look at the overdoses in 2016 across the country for opiate overdoses, in close to 30% of the overdoses around the country, you can find traces of benzodiazepines in the system. And now that we have prescription drug monitoring in each state, we looked at the results of the prescribed controlled drugs in Connecticut, for instance, and 4 of the 5 drugs were benzodiazepines. It was Xanax, it was Klonopin, it was Ativan, and Ambien. And only the Oxycontin made the top 5 of the medications as an opiate analgesic. The other 4 were benzos. So again, it's getting overshadowed by the benzos, but it has a significant contribution to some of these overdoses. And on college campuses and in high schools now, kids are seeing it and perceiving it as a low risk. Obviously, it's FDA approved, and sometimes they received it from their doctors for anxiety, and now there's such a focus on opiate analgesics and staying away from that kids are seeing this as pretty harmless, yet when they mix it with alcohol, it can be tragic. And then trying to come off these benzos on their own without a medical detox can be life-threatening. People can have seizures, like 3 days going, cold turkey, as they would say, from benzos. So the key is to have a medical monitoring for detox. And in our detox, for instance, in Mountainside, we have a 5-day protocol for alcohol to come off of alcohol dependence, 5 days for opiate dependence, but a 10-day protocol for benzodiazepines because it's so difficult to actually come off them.
Do many people or most people who are addicted to opioids, are they also addicted to these benzos?
Well, it's interesting because the jury's still out on some of the individuals that, for instance, in methadone programs across the country, there's about 20% of people that are presently on methadone programs that are also using benzodiazepines, but the jury's still out on whether or not those individuals are just not comfortable in their own skin. And even though they're having their opiate addiction treated with medication-assisted treatment, that they may still be self-medicating or medicating an anxiety, pre-existing or co-occurring anxiety disorder. So there's a cohort of individuals that do need to receive treatment for anxiety, but then there's another cohort of individuals that will use the benzos to get high because it has a synergistic effect both with alcohol and opiates to actually kind of induce a high where there's that cohort, as I say, that may still be drug seeking for an actual high experience, but then there's that other cohort that are actually using it just to be comfortable in their own skin.
As we've been talking about, hearing so much about this opioid epidemic, I'm hearing rumors of states beginning to sue individual companies, distributors of pharmaceuticals, of opioids across the country. Do you see that trend on the horizon when it comes to these benzos? Because at some point, we're going to have to see some information saying that these are just as bad as the opioids that are being so vilified right now.
That's a great point. And actually, I think there has been some cases already. There was one that I'm familiar with in Connecticut where a patient sued her doctor for becoming dependent on these benzodiazepines because it was so difficult to come off. So I do think that could be the next level of litigation for doctors that may not have responsibly prescribed this medication for their patients, particularly if their patients suffer from other substance use disorders, such as alcohol substance use disorder, where if they're getting prescribed on an ongoing basis benzodiazepines, they could die. It becomes something that puts them in harm's way, and there are physicians out there that unfortunately need to be better educated to understand some of the dangers in overprescribing this medication, or even just to recognize that prescribing this medication long-term is not the standard of care that exists in the country today for anxiety.
As a healthcare professional involved in addiction and treatment, what do you see on the horizon when it comes to educating folks such as yourself and other healthcare practitioners when it comes to opioids? Obviously, they had a certain face throughout the decades for use and prescriptions. But now that this opioid epidemic has taken place, there are programs in place such as CASPR in some states that regulate the distribution of these drugs. What do you see on the horizon as education when it comes to preparing counselors for addiction, just getting rid of opioids altogether and stop basically talking about them as an alternative or an option for pain relief?
Yeah, so I know they're looking at some fast-tracking some clinical trials to look at non-opiate pain management, and they actually have some that exist now. So, we first have to do no harm and hold harmless those that are suffering from chronic pain. And I think the whole field of pain management needs to partner with the field of addiction to make sure that those that truly need this medication will not suffer and reduce that access. There's also the issue of, great efforts, as you mentioned, through the states of controlling the number of opiates that people leave a hospital with. Like there's some research that suggests that if you have a 30-day supply of opiate analgesics leaving the hospital, you have a 40% chance of still taking those analgesics 12 months later. Mm-hmm. So to actually reduce the amount of increased exposure to the medication will increase the risk of addiction. And that's a key piece, but that is actually an issue around supply. But the reality is there's still a demand there. So there may be a cohort of individuals that inadvertently, because we put restrictions on these opiate analgesics, will turn to the streets for heroin once they are dependent on these opiates. So we just have to be really careful that we need a multifaceted approach to not just address regulations around supply, but regulations around not regulations around demand, but access for treatment and timely access to give people treatment and to work on challenging some of the stigma around treatment and discrimination around treatment to have people be able to get that help that they need. Because today only 15% of Americans that would qualify for treatment, opiate treatment, are actually seeking treatment in the last 12 months. So we can do a better job of engagement And I think we have to look at that on all levels and see addiction as a chronic disease like any other chronic disease that could be, treated in a hospital, treating in any setting, obviously diverting it from the criminal justice system when it's a nonviolent offense and trying to get people treatment instead of incarceration. There's many different efforts we could make towards making some progress with this. But I do think that, yes, there's going to be new mechanisms that will be less addicting and where people will be less dependent on them, but I don't see it coming out anytime soon.
Well, give us a website where we can learn some more about Mountainside Addiction Treatment Center.
Oh, yeah. Well, we have mountainside.com. Just look it up, and we offer a continuum of care for residential, for detox, for outpatient services, for medication-assisted treatment and recovery coaching. We see addiction as a chronic disease, so we can offer people extended care and support up to a year for that first vital year of recovery, because that's when people are at greatest risk for relapses in that first year. So we can offer that ongoing support when appropriate.
Thank you, John, for coming in and taking the time with us today.
Oh, it's my pleasure. Keep up the good work.
You've been listening to Health Professional Radio. I'm your host, Neil Howard. Transcripts and audio of this program are available at hpr.fm, healthprofessionalradio.com.au. You can subscribe to the podcast on iTunes, listen in, and download at SoundCloud, and be sure and visit our affiliates page at healthprofessionalradio.com.au.